Good evening. Thank you for this kind invitation. Thank you to Miltos Balidis. It is an honor for me to be with you, with Renato Ambrosio, with Damien Gatinel, with Dimitrios Sakellaris, with Miltos at this second Keratoconus Day online meeting. We speak about keratoconus progression in patients with allergy and elevated surface matrix metalloproteinases. The correlation between allergy and keratoconus was reported first by Hilgartner in 1937 and was well known. There are a lot of evidence actually that changed the paradigm of the keratoconus old definition as only a degenerative disease. We know that such results suggest like Charles McMonis also demonstrated, that keratoconus cannot be defined only as non-inflammatory degenerative disorder, but in the pathogenesis of the disease, a lot of factors such as traumatic factors and chronic inflammation events could be involved in the development and the progression. We have a lot of evidence of inflammatory processes just published in the literature, both in contact lens wearers and non-contact lens wearers, in atopic and allergic patients, in patients suffering from blepharitis, rosacea, and rubbing-related corneal traumatism, degradative enzyme hyperactivity, and tear dysfunctions, dry eye, meibomian gland dysfunction, the evidence of reduced anti-inflammatory capacity of the tears, indicated in keratoconus with the reduced lactoferrin level, lipofilin A and C level, the reduced immunoglobulin, and increased the albumin in the tears, suggesting failure also of the blood-ocular barrier in the conjunctival vessels with the typical hyperemia of the conjunctiva, the typical photophobia, extreme photophobia of these patients who rub a lot their eyes. There is a very interesting review from my friend Robert Wiese. It was published in the Ocular Surface in 2015, showing the higher level of metalloproteinases, in particular the 9 in the tears, but also in the epithelium of these subjects with reduced levels of the lysyl oxidase 2 enzyme and the family of lysyl oxidase enzyme in all corneal level layers, and the increase of pro-inflammatory factors such as interleukin 1 alpha and 1 beta, and also the increase of pro-apoptotic effect of interleukin 1 with the tumor necrosis factor, and also the increased level of metalloproteinases. What we want to say is that there is a model of interaction between soluble inflammatory mediators, keratocytes, causing stromal collagen remodeling that is typical of keratoconus, with stromal volume depletion, slippage of collagen, deformation of the corneal profile, and also the stromal thinning. Of course, I think that always there is a genetic susceptibility, and the environmental factors such as eye rubbing increase the overexpression and concentration of soluble immunomediators, binding receptors of stromal keratocytes, thus increasing the protease activity after rubbing, allergy, inflammation, chronic inflammation, stimulating keratocytes, interleukin apoptosis, and also the transforming growth factors may induce differentiation of keratocytes into myofibroblasts and the transformation to fibroblasts with fibrotic phenomena, and the over biomechanical and biochemical modification stimulating extracellular matrix in the complex of collagen proteoglycans, remodeling the tissue distribution with slippage of interlamellae, and the volume depletion with the classical thinning of keratoconus. So it has been proven clearly that eye rubbing increased level of tumor matrix metalloproteinases, interleukins, and tumor necrosis factor, even in normal subjects, contributing to the development and the progression of keratoconus, like in the studies of Balasubramanian and Wilkers, that was clearly demonstrated. Also, inflammation keratoconus, it has been proven acute and post-acute corneal eye drops in pediatrics eye rubbers suffering from allergy. So we know it is clear that allergy and eye rubbing promote and accelerate keratoconus progression. It is in particular evident that the one-year progression rate that was reported by Schatzi and Afezi in the literature of 88% of progression pediatric population of keratoconus becomes 100% in one eye in allergic patients suffering from allergy and eye rubbing. So I have published an interesting work in Eye and Contact Lens in 2017 showing the keratoconus progression was higher in allergic patients with eye rubbing and elevated surface matrix metalloproteinases that were measured by a point of care test. You know that it is inflammatory. I don't have any financial interest, of course. We studied 100 patients in stage 1-2 keratoconus, dividing them into groups. The first group of 52 patients was positive to anamnesis for allergy, rhinitis, allergic conjunctivitis, asthma, and various associations. And 48 patients were non-allergic at anamnesis. And eye rubbing was found in 100% of the allergic group and in 16% of the non-allergic group. The inflammatory test positivity was 81% in the allergic group with keratoconus and only 4%. And the 4% of non-allergic were eye rubbers, of course. So we excluded from this study the dry eye patients with the OSD test. We excluded from Schirmer tear test and also with non-invasive breakup time testing. We graduated also the papillary subtarsal hypertrophic response from absent to high, and of course we tested the metalloproteinases. The normal level range in the tear film of metalloproteinases are between 3 nanogram per milliliters to 14 nanogram per milliliter. So this is the RPS test from Sarasota. There is a direct sampling microfiltration test, and the positive test results indicate the presence of metalloproteinases number 9 on tear fluid over 40 nanograms per milliliter. So what we show it with the black line that represent the allergic group, that we have an higher progression, a visual decay that worsened better in most importantly in the allergic group compared with the non-allergic. Also Kmax increase tremendously in these allergic patients with contemporary corneal thinning, and also the eye gourd aberration, particular coma-like aberration, increased contemporary in allergic patients, and you can see here the red arrows. Another important correlation test Pearson showed that in the graphic A here, the highest correlation between Kmax increasing and corneal thickness reduction was shown particularly in the keratoconus allergic group with a Pearson value test of minus 0.85. And the box plot testing showed that maximum increase of Kmax is correlated with the highest hypertrophic papillary subtarsal response recorded in the keratoconus allergic group. Indeed, the test showed that the increase of Kmax was greater in box 3 and the box 4 corresponding to keratoconic allergic patients with grade 2 and 3, so the higher grades of the hypertrophy papillary subtarsal response. We did also the exact Fisher test, the two-tailored Fisher test that showed the correlation between the positivity between the inflammatory test and the eye rubbing, confirming that a statistically significant value from the correlation between eye rubbing and the positivity of the MMP9 point of care test in patients with keratoconus and allergy. So the association within pediatric age allergy and eye rubbing may represent, of course, a dangerous situation, stimulating a really faster progression. And take into account also that patients who tested positive to MMP9 test in the keratoconus non-allergic group belongs, of course, to eye rubbers. So the study demonstrates that a concomitant allergy may increase keratoconus progression, especially in severe untreated eye rubbers cases. And I also showed this in my publication of 10 years results in cross-linking in pediatrics, where the 4.2% of retreated patients belongs all to eye rubbers allergic patients. So, to take home message, we need to highlight the higher potentiality of ectasia progression in pediatric patients suffering from allergy and rubbing by providing appropriate screening and improving care for atopy and allergy. We need to stress the importance, of course, of choosing eye rubbing, like Renato Ambrosio stressed, and also Damien stressed this concept very well. We need to close tomographic corneal monitoring to eye rubbers and allergic atopic patients, children in particular, for the risk of ectasia development, progression, eye drops, and performing cross-linking without awaiting further progressions. And we need to manage, to recognize and manage allergic conjunctivitis with topical antihistamine and mast cell stabilizers, steroids, preservative-free lubricants, and also cyclosporin A may be used in severe cases of giant papillary conjunctivitis or in vernal keratoconjunctivitis patients. So we need to alert pediatricians and ophthalmologists for yearly keratoconus screening in the eye rubbers allergic young patients. I thank you for the attention.